Hi everyone, my name is Kelsey Brown and I am going to be presenting my evidence-based implementation proposal of surgical smoke evacuators and implementing a policy that will demonstrate best practice in the operating room. Some of the goals and objectives we'll be discussing in this presentation is knowing and understanding what surgical smoke is and what smoke evacuators are. We will be stating the problem of surgical smoke and going over some background information, reviewing the PO question that was created for my department, and we'll be also talking about the evidence-based implementation intervention plan process, documentation of findings, plans for analysis, and obstacles for this proposal. As medical research has advanced and people are becoming more aware of how harmful smoke is on your health, smoking has become banned from most public places. Surgical smoke, also known as surgical plume, is a global issue in the surgical setting. Surgical smoke is created by electrocautery and laser machines that are used in various specialties in the operating room. For example, laser machines are used in a lot of urology cases and most pacemaker lead extractions. And cautery machines are used in almost every specialty in almost every surgical case. Cautery machines are used to cut tissue and control bleeding by coagulating blood vessels. According to the CDC, they have confirmed that smoke contains toxic gases and vapors. Surgical smoke causes hazardous health for patients and surgical staff. According to the Association of Perioperative Registered Nurse Journal, studies have shown that using a carbon dioxide laser is equivalent to smoking 3 unfiltered cigarettes in 15 minutes, and the use of an electrocautery machine is equivalent to smoking 6 unfiltered cigarettes in 15 minutes. Those numbers are very scary to hear. Adverse health outcomes related to surgical smoke exposure have been reported, such as HPV, cancer, and bacterial infections. Becoming aware of potential risks and taking precautions is vital. Smoke evacuators contain a suction unit, filter, hose, and an inlet nozzle, which is a high-efficiency tool used to reduce airborne particles according to the CDC. Smoke evacuators are used to filter the air and migrate surgical toxins in the air. According to the United States Department of Labor, under the General Duty Clause, Section 5A1 of the Occupational Safety and Health Act of 1970, employers are required to provide their employees with a place of an employment that is free from recognized hazards that are causing or likely to cause death or serious physical harm. The perioperative team and patient is at risk for exposure of surgical smoke, and smoke evacuators should be used in any surgical case that anticipates surgical smoke. There are many products in today's technology, such as ConMed Clearview Smoke Evacuation Unit. This is just one example of a smoke evacuator which eliminates 99.999% of smoke contaminants. Eliminating surgical smoke in the operating room allows for a healthier and safer work environment for all staff that work in the operating room. This also falls under the nursing theories of Florence Nightingale, keeping the OR in a safe environment for patients. Smoke evacuators should be utilized in any procedure that anticipates surgical smoke. AORN is one of the world's largest professional organizations in the perioperative nurses that provides evidence-based guidelines. AORN recommends the use of smoke evacuators in all surgical cases that anticipate surgical smoke. In the perioperative department, we try to follow all AORN guidelines, however, this best practice is being skipped. AORN provides a Go Clear program for the department to follow for easy implementation with templates of policies and success stories. The Go Clear program consists of a pre-survey, educational information, implementation plan, and an audit and post-survey. And I plan to utilize the Go Clear program in my implementation plan, which you'll see further on in this presentation. Currently, we do not utilize any of the technology options to clear the air from surgical smoke. Yale Health System has changed policies in some of their locations, such as Westerly and their Bridgeport campus. One would think in such a large organization they would unify all locations, but they have not created a policy or set positive standards at their Yale New Haven campus. The Yale New Haven campus currently has policies for their cautery machines and laser machines. However, surgical smoke isn't explained in those policies, or how to prevent the surgical smoke created from the cautery and laser machines. Yale New Haven does not have a policy for surgical smoke. I believe implementing a policy will be extremely easy, with either altering the policies already in place with the laser and cautery machines, or utilizing one of Yale's already existing policies at their Westerly or Bridgeport campus. I could also just use one of the templates the Go Clear program has for people to use. I can present all this to the shared governance when submitting in that process, which you'll hear later on as well. For this evidence-based implementation proposal, I created a PO question, which is, will revising and implementing a new policy regarding the use of smoke evacuators in the perioperative area demonstrate best practice? Based off this question, I performed a literature review, which we'll be going over next. Based off the PO question, this is the literature review that I performed, and I found that most of my articles were quantitative research, which I found most helpful in my journey. Here's just an overview of the research articles, and the next 5 slides we will be discussing each of these articles more in depth. The purpose of this study was to determine the status of the exposure of surgical smoke for surgical staff and determine the negative side effects that surgical staff experience related to surgical smoke. This quantitative study, descriptive study, was done by studying 54 operating room nurses from 2 large hospitals at Trakya University Medical Facility and the Istanbul University Kappa Medical Facility. This study gave nurses a questionnaire asking their experience with surgical smoke. 92.6% reported they understand the meaning of surgical smoke, while 55.6% are aware of the negative side effects surgical smoke offers. Almost 60% of nurses stated they get headaches and sore throat irritation from surgical smoke. In this study, smoke evacuators were not consistently used or even in the room. This study is significant to my proposal to show that a pre-questionnaire will be significant in my implementation to see where the staff stands on their knowledge and understanding of surgical smoke and the side effects and what our policies are. We will be able to alter the education based off the results that we receive. This article shows that smoke evacuators are not consistently used or even in the room. Having a smoke evacuator in every operating room will eliminate that barrier. This study was sought to examine the patient's perception of surgical smoke. This quantitative experimental design study was used on 30 patients that participated in a comparative trial undergoing Mohs procedure, which undergoes 2 stages in the procedure. The first stage did not utilize a smoke evacuator, and the second stage, which requires the use of more cautery, used the smoke evacuator. In this study, the patients were blindfolded, 17 were male, 13 were female, and the average age was 71. The results showed that 100% of the patients reported the perception of a burning odor during the first stage, which didn't use a smoke evacuator, and 40% reported an odor during the second stage, which uses cautery more and uses smoke evacuator. 66% of patients reported the odor as unpleasant, and 63% of patients thought the smoke evacuator was a more pleasant experience. As you can see, not using a smoke evacuator, the results were 100% of the patients reporting a odor smell. And when they used more of a cautery and used the smoke evacuator, the number dropped 60%. This study is significant to my proposal to show that patients need a clean and healthier environment, which is related to the Florence Nightingale theory. Smoke evacuators should be implemented to protect the patient from surgical smoke and provide them with a more enjoyable procedure. This study was sought to examine the patient's exposure of organic substances produced and identified in surgical smoke performed in the abdominal cavity during a laparoscopic cholecystectomy. This qualitative study identified what was in surgical smoke, and this qualitative analysis of smoke produced during a laparoscopic procedures revealed the presence of a wide variety of toxins. All patients undergoing laparoscopic procedures are at risk of absorbing and excreting smoke byproducts. This study is significant to my proposal to show that the patients need a clear and healthier environment, which is related again to the Florence Nightingale theory. Smoke evacuators should be implemented to protect the patient from surgical smoke. The purpose of this study is to examine the health-related problems to surgical smoke generated in the operating room experienced by nurses and physicians in the surgical setting. This quantitative descriptive study was carried out in the operating rooms of a training and research hospital with 81 nurses and doctors. This descriptive statistical analysis was performed using a SPSS software package. It was conducted voluntarily on 45 nurses and surgical technicians and 36 surgeons. The results of the study determined the geographical information in discussing the population tested, as well as the problems associated with surgical smoke. The study revealed that nurses and doctors do have adverse side effects related to surgical smoke. Staff wears surgical masks and cases, but do not always use smoke evacuators to prevent the surgical smoke side effects. Staff has a lack of using these smoke evacuators. They have a lack of knowledge of the education and of a lack of their knowledge of the protocol. Establishing a safe environment for staff is of the utmost importance. This study is significant to my proposal to show that the side effects that the surgical staff experience, the proposed implementation would eliminate these side effects experiences by using smoke evacuators. Staff would be properly educated and also know the protocol that is in place. The purpose of this study is sought to examine smoke particles and to understand how harmful surgical smoke is for staff. This quantitative experimental design study was used to examine surgical smoke particles. They used an electrical low pressure impactor with a filter stage and additional impactor stage for real-time particle number, mass, size, distribution measurements. This study shows mass distributions and size varied between tissues samples depending on the area that was cauterized. 3 classes can be determined from the sample of smoke production. Liver produces the highest number of particles, while renal and skeletal muscle produces medium amount of particles, and skin and gray matter produce low-level particles. Results indicate that you should be utilizing the smoke evacuator for all surgical cases that produce surgical smoke. This study is significant to my proposal to show that the surgical smoke evacuators need to be utilized in every surgical case that anticipates surgical smoke for the benefit of patients and staff. This provides for a clean air and clean environment for the staff and patients. For my evidence-based implementation intervention plan, I plan on doing a 6-month goal for this process, which I think is very obtainable for this whole implementation process. I plan to submit a shared governance policy change or implementation of a policy first, because I hear that this whole shared governance process will probably take the longest amount of time. In the shared governance process, I will submit what policies you already have in place, what the other facilities' policies are for surgical smoke, and also I will submit the AORN Go Clear program recommendation policy to see what they would like to use. The policy needs to be very clear so all staff has no confusion of what surgical smoke is and what we need to be doing for smoke evacuators. We will then perform a pre-survey to see where staff is and their knowledge of surgical smoke, our policy, and side effects of surgical smoke. We will provide education based off those results and also provide meetings to bring more attention to it, such as journal club meetings. I will also then provide a smoke evacuator in every operating room, providing an in-service for all staff. We will then implement this evidence-based practice and then perform an audit to determine the compliance and staff's perception of having less surgical smoke. This will also determine to see if there's any unknown barriers and determine what the staff's perception is of the new policy. We will need to perform routine audits to keep up with the compliance. We will also provide a post-survey for any additional follow-up. We can utilize Roy's adaptation model and utilize his framework for this intervention plan. Launching this smoke evacuation evidence-based practice plan, we might encounter some barriers and obstacles. However, this implementation plan we previously discussed should eliminate barriers and obstacles. We're going to start to have more discussions and meetings about surgical smoke to get more people on board. This will get the surgeons more on board and eliminate that barrier. I'm having a journal club meeting this Wednesday that I have once a month, and we're going to be discussing surgical smoke and smoke evacuators this Wednesday. Some of these surgeons work at the other facilities that mandate smoke evacuators, so some of them, this policy will not be an issue. With the limitation of equipment, we will be placing a smoke evacuator in each OR, so that will eliminate any obstacles for the nurses trying to find equipment or not having one available for their case. We will be measuring outcomes based off of the audits performed, and also we will know that this implementation was successful by having staff have a better perception of having a cleaner and healthier work environment. That will show successful implementation for this evidence-based practice that is best for our department. We have previously discussed obstacles and any barriers we might encounter, and any additionals that we might encounter will be discussed in the meetings discussing the outcomes. We can discuss the outcomes in our daily safety huddles that all key stakeholders are part of. Our outcomes will be used to show all key players that this evidence-based practice was critical for our department, for staff and patients, to providing a clean and healthier environment. This should be a hospital-wide policy. I am part of the Quality and Safety Committee, and I am determined to get this up and running to provide a safe environment for everyone. Becoming aware of the potential risks and taking precautions will demonstrate best practice by protecting patients, your team, and yourself. With this presentation, you should have become more aware of what surgical smoke is and how to eliminate it in the operating room. I think this evidence-based implementation plan will show you all the steps that will be used to initiate this evidence-based practice in my department. I hope everyone understands the surgical smoke effects on patients, staff, and how this evidence-based proposal is appropriate for my department.